Good evening. Come back again, all doctors, young budding doctors. Today we'll have a session on communicable diseases, session number 2. Before that, we'll have a small chat on Auricle. Auricle is a very good platform for rapid revision of all the important questions in your exams, and it gives quick fact revisions. It is on deep diving in topics, and most of the important topics will be covered in your Auricle platforms, and it is beneficial for the students who are going attending for exams as well as the entrance exams and the next exams. We'll be covering long essays and short essays today, which is long essays includes rationale behind pulse polio immunization and what are the main activities which were conducted under the National Immunization Program, that is National Pulse Polio Immunization Campaign in India, and what are the epidemiological factors contributing to acute diarrheal diseases, and we'll discuss briefly about prevention and control measures of the same. In short answers, we'll be discussing about Chandler's index, which is the ancient one, and the importance of it, and hepatitis B, modes of transmission, prevention, and control. And the third question will be typhoid fever, epidemiological features, prevention, and control. Why did we choose Auricle? Because we get the 5 different types of advantages. One is record classes, live classes, practical sessions, exam modules, and hard copy book sets. You can use anywhere, wherever you want, and you can read and prepare for your exams wherever you go. Recorded classes gives you flexible learning between whenever you have time, you can revisit the topics, revisions classes, and it gives the complete foundation by our expert instructors who are not less than 10 years of experience, and it helps in convenient revision for your exams and reducing the exams pressures on you. Better preparation are inversely proportional to stress and pressure of the exams. So Auricle will try to help you do this with in a simpler and the easiest way. Live classes give you the complete comprehensive over the topics by the experienced educators, and we'll have an interactive session and doubt clearance also including we'll have MCQs, whereas Viva OC and many more. And this was designed after 45 days of live classes. Express exam modules will be completing all your topics or the syllabus of all PSM or any subject in 20 hours, which is not provided by any other platforms as of now, that of to my knowledge. And complete syllabus is in comprehensive and efficient coverage, and you will be taught how to write the answers by our expert educators, and you can use these strategies in your exams, and you'll be well prepared for your exams, and it will help you excel more and get more marks during your exams. One-to-one doubts clearing session will also be there. If an individual has any doubts, will be student-centric approach. All questions will be answered. How small or silly it doesn't matter. Doubt is always a doubt. It should be cleared. And personal attention will be given to all the students. And it's a safe learning environment. You can ask your questions without any fear of being judgmental in a supportive or understanding setting. No one will be ever judgmental about you for your questions here. Not the least, you will get your hard copies for your fast track preparations, and experienced educators will give you and guide you for your exams by giving you concepts, facts, and study plans, and many more. And we'll have the interactive sessions in a very regular and in more numbers. Apart from that, you'll have a question bank from beginner till expertise, and you will have a question banks for your readiness that contains most commonly previous year question papers, both for NEET, PG, FMG, and your university exams. Practical sessions will give you hands-on experience and expert guidance from our teachers, and also you can excel practical examinations in a very easy way. This is one of the place where you can gain good marks when you control your examiner. We help you do that in a simpler way. We have 4 subscription plans, that is foundation plan, advanced plan, complete learning plan, ultimate MBBS plan. Foundation plan is for 3 months, which costs around 19,999, and advanced learning plan is for 6 months, which is 32,999, and complete learning plan is for 12 months, that is a year, for 59,999, and ultimate MBBS plan is for 18,9999, which is completely includes your full MBBS course. And please do not forget to use the code displayed below for your subscription discounts. You will have very good discounts. Thanks for watching. Now we will start off with our topics for today. That is, what is the rationale behind pulse polio immunization? List the main activities under National Pulse Polio Immunization Campaign in India. Pulse polio immunization. Pulse polio immunization was, will write this answer in the topics exactly as per the slides. Please take it down so that you will not be missing any point. And all the points are very important to gain marks in a long essay. First, you will write the introduction. That is, pulse polio immunization program was developed systematically to eliminate poliomyelitis, which is a viral disease that primarily affects young children. Why? Because it was causing lifelong paralysis, and in some cases it was fatal. And this was launched in 1995, and children in the age group of 0 to 5 years were given polio drops during national and sub-national immunization rounds. When were the sub-national immunization rounds were conducted? Only in the high-risk areas, and it is done every year. Okay. Around 17.4 children of less than 5 years across the country are given polio drops as a part of the drive. By whom? By Government of India. To what? To sustain polio eradication from the country. We have eradicated polio in the year 2014, and to maintain this, still we are following the pulse polio immunization program. What was the objective of this program? Pulse polio was started with an objective of achieving 100% coverage under oral polio vaccine. It was aimed to immunize children through social mobilization, plan mop-up areas where poliovirus has almost disappeared, and maintain high level of morale among the public. This was the objective. And what was the rationale behind this? The rationale was polio was interrupting the poliovirus transmission. That was the first rationale. And we all know it is spread through fecal-oral route, and it is because of poor sanitation. Once a person, especially a child, is infected with the virus, they can spread it to others even if they do not show any symptoms at all. The child wouldn't have any symptoms, but still the child used to spread the virus. And how did this virus spread? And where did it survive? It survived in sewage and contaminated water and maintained the high risk for transmission. How did we interrupt this? By administering the oral polio vaccine to all children under 5 years of age during the special immunization drives. This chain was broken. The mass immunization, that is the large number of children were immunized at a single instant, ensured that they cannot pass the virus, because most of the virus which was causing the polio was not able to spread, because the virus which was there in the polio was multiplying and spreading and stopping the virus which was causing polio. That means the live attenuated virus which was given to children was multiplied in a huge number in children, and it was present in the environment, so that the wild polio virus was not able to infect the children, and it was protecting the children from the wild polio virus. What did we call this? This is called as herd immunity. In case of polio, achieving high levels of immunity in children reduces the virus ability to find susceptible hosts. This led to the interruption of its spread, which spread, that is wild polio virus spread. The second rationale was universal immunization coverage. Routine immunization programs were effective, but some children were left unvaccinated due to logistical challenges, like unable to reach to the areas where there was a cutoff, like high altitude areas, and where the areas were in tribal areas, jungles, and where the children were very far off villages where there was no road connectivity and there were no awareness and there were socio-economic barriers. If the child would have been brought to the hospital, then the parents would have lost their daily earning. That was the socio-economic barriers, which was the major hindrance for the children to not get vaccinated. And this pulse polio campaign addressed this gap by ensuring that every child is vaccinated regardless of their previous immunization status. How? By doing door-to-door visits and by creating mobile health units and involving the community heads, that is the village panchayats, zilla parishads, etc. The campaign specifically targeted all the children who were under the age of 5 and who were more susceptible to polio, and it was a focus of the global polio eradication initiative also. Preventing the circulation of wild poliovirus. Wild poliovirus exists in two forms. That is, poliovirus usually exists in two forms. That is, wild poliovirus and vaccine-derived poliovirus. What was the target? Wild polio was the original target of this campaign. By vaccinating all children in the short period, the virus deprived of host. That means the vaccine-derived polio virus was there in the children, and wild polio virus did not get any host to multiply. In India, there were multiple rounds of PPA were conducted. Pulse polio immunization was conducted every year to reduce the number of host, that is susceptible children. Hence, this led to the reduction of multiplication of wild polio virus. As the virus continues, that is vaccine derived virus continues to circulate in high risk environments, the wild polio virus multiplication came low. This is known as maintaining of high level of herd immunity. What this led to was this prevented the potential outbreaks of polio infections in India. What is supplementary immunization and routine immunization? Routine immunization schedules were never necessary to get the high coverage because the children were in the different age groups. And the children were not coming to the hospitals to get the vaccinations. So hence the supplementary immunization activities were carried out. What were the supplementary immunization activities? Examples are Pulse Polio campaign and the recent one is Mission Indradhanush. These campaigns ensured that no child was missed, how far the child was staying, or in whatever the area, whether it is a high risk area or low risk area, the children were immunized to achieve the 100% coverage. Even though their previous immunization status was adequate, still the immunization was done. Coming to what is the other rationale of doing this pulse polio immunization? India is such a country where there are large number of migrants, travelers, and nomadic communities. Why? For the sake of job and livelihood. And these populations were at high risk of carrying the virus from different areas or the different geographical parts of the country to the parts where it was a low risk areas. And when they come over to the new areas, either they live in a poor conditions or overcrowded conditions. This pulse polio campaign specifically targeted these groups by what? By setting up mobile vaccination units and establishing the temporary immunization booths at transit points. Where are the transit points? That is bus stops, train stations, and border areas. By doing this, it was ensured that no child was missed during the vaccination. What are the main activities under National Pulse Polio Immunization Program? First one, on the national immunization days, that is a designated day, and usually it will be a Sunday. Why? The children and the parents are on leave so that they can come and get vaccinated. And the mass vaccination drives are conducted where the children under 5 years receive oral polio vaccine. These days were publicly announced and they were given a very good coverage of publicity and ensured there was a maximum participation. The immunization helped the simul happen like all over the country on a single day. That is, one single day we have the national immunization program. Booth-based activities. What does it mean? Yeah. Vaccination booths are set up at various locations such as schools, health centers, bus, train stations, markets, and community centers. Where all the people on Sundays, where all the parents go with the children, whether it could be an entertainment area or traveling, all these areas were covered on a single day. The booths were kept open for the complete day, allowing their parents can come and get their children vaccinated at any point of time. And special booths were set up for high risk locations, like we say Jopatpatti or any transit points or where the migrant workers are staying to cover the maximum children. House to house vaccination. Once the booth vaccination was done, house to house vaccination was carried out for the next 3 to 4 days. Why? If there are any children who were missed, these children were covered on those days. Who will do this house to house vaccination? Health workers and volunteers, they visit homes in both urban and all the areas, ensuring that no child has been left out. In some parts of the country, we call them as Asha workers and female welfare assistants who are going to do the house to house vaccination, including the Anganwadi workers also. Mobile vaccination teams. In addition to the fixed booths, mobile teams are deployed to immunization children in the hard to reach areas like tribal villages or the pockets where the students are staying, where the children are staying in the different or hard to reach where there is no road connectivity. All these things were covered during the mobilization teams. These teams were giving a comprehensive coverage and where there are limited access to healthcare. Apart from these, the staff who were used to conduct for pulse polio immunization also, they were supposed to do the surveillance for acute flaccid paralysis. Why? To check whether there is any infection of polio and to investigate all the cases under the children for polio infected acute flaccid paralysis. If there is any confirmed case of polio, leads to immediate mop-up immunization rounds. That means if any child comes with the symptoms of acute flaccid paralysis and it turns out to be a polio, there will be one more mop-up immunization round in the affected area. Why? To stop the further transmission. And sixth rationale was social mobilization and awareness campaign. So it's not the rationale, it is the activity. During this mobilization, there were announcements made in the TV, news, newspapers, radios, everywhere. Even the volunteers and NGOs took up a close work with the health departments to conduct door-to-door information sessions by distributing the flyers, pamphlets, both in local messages, like involving a celebrity also was done for the awareness campaigns. Like Do Bon Zindagi Ki was one of the statements which were used. Apart from not only the government, the non-government agencies were also involved, like World Health Organization and Rotary International, UNICEF, these were also involved for both monetary and non-monetary helps. What are the other activities? There were usually bivalent oral polio vaccine has been used. Please do not write as monovalent. Initially, the trivalent was used. Now it has been bivalent oral polio vaccines are the vaccines which are used. What are the bivalent which are used? Type 1 and type 3. What it helps, this tailored the approach helps in eliminating circulating strains more effectively. And there's a switchover of vaccination from OPV to IPV. And it does not happen in a very fast pace. It takes its own time and it happens in a slow and dedicated manner. How the targeting of high-risk areas were done? First, the high-risk areas were identified. High-risk population and high-risk areas were identified, such as slums, nomadic populations, and regions with low routine immunization coverage. Later, they were decided whether there were polio transmission or not, and efforts are made to vaccinate these children through mobile units. Instead of asking them to come to the hospital, the mobile units were sent and rounds of house to house visits were conducted. And cross-border collaboration. This is important because we share borders with many other countries like Pakistan, China, and Bangladesh, Nepal, and Bhutan too, and Myanmar. So we don't want any of the countries to share their infection with our infection. So to avoid this, we engage immunization activities like with our neighboring countries, especially in the border areas. With this, we have completed our first question. We'll come to our second question, that is, what are the epidemiological factors contributing to acute diarrheal diseases? And we'll discuss briefly about its prevention and control measures. Take a 5-second break. We'll start with this question so that your mind gets cleared. Coming to the introduction, definition. What is the definition of diarrheal disease? It is defined as passage of loose stools or liquid or watery stools, usually for more than 3 times a day. It is for you to remember for your viva that it is not important to note that it is not change in consistency and character of stools rather than number of stools. If someone is having stools of 4 times a day, and if there is no change in consistency or character, then we don't say it is a loose stools or a diarrhea. If someone is having stools of 2 times a day, but it is running like watery, then we call it as a diarrhea. So it is not the number of times which is important. It is the change in consistency and the character of the stools, which is more important. For definition purpose, we can write it as passed more than 3 times a day, which should be loose, liquid, or watery. What are the types of diarrheal diseases? We can classify into 4 different types. That is acute watery diarrhea, acute bloody diarrhea, persistent diarrhea, and diarrhea with malnutrition, severe malnutrition. Acute diarrhea, it lasts for hours to number of days. What is the main dangerous thing in this? That is dehydration. The dehydration is very rapid. And what are the pathogens which causes watery diarrhea? That is cholera, E. coli, and rotavirus. The most 3 common pathogens are these 3. Vibrio cholera, E. coli, and rotavirus are the 3 pathogens which cause acute watery diarrhea. Acute bloody diarrhea, which is also called as dysentery, which we call it as blood in stools. What are the dangers of this acute bloody diarrhea? It is not just the dehydration. We have along with this is something called damage to intestinal mucosa. Why we are getting blood in the stools? With the damage of intestinal mucosa, which is leading to sepsis, and again it leads to malnutrition. This is the one of the dangerous things which happens in acute bloody diarrhea. The third one is persistent diarrhea. it lasts for 14 days or more. That is more than 2 weeks. The dangerous things to happen in this is malnutrition, non-intestinal infection, and dehydration. That means you can go into sepsis later or generalized infection over the body. And the fourth type is diarrhea with severe malnutrition. That means there is a pre-existing cause. There may be associated with marasmus and kwashiorkor, which may lead to severe systemic infection in the later stages, dehydration, heart failure, vitamin and mineral deficiencies. All these things can happen during diarrhea with severe malnutrition in children. Please try to remember any communicable disease. If it is possible to draw an epidemiological triad, please do draw. Agent, host, environment, and a small triangle in the between, that is acute diarrheal diseases. Agents are of three types. We can classify into three types: virus, bacteria, and others. Others include parasites and other worms, etc. Virus, the most common is rotavirus, and the other viruses which are listed are very rare. Enterovirus might cause some, but rotavirus is the most common one. Rotavirus, astrovirus, adeno, calci, corona, norwalk group of virus, enterovirus, and cytomegaloviruses. These are the most important ones. In bacteria, we go with Campylobacter, and including all types, that is enterotoxigenic, invasive, and hemorrhagic E. coli. Shigella, Vibrio cholera, Vibrio parahemolyticus, Bacillus cereus, Staph aureus, Clostridium perfringens, Clostridium difficile, Yersinia enterocolitica, and Chlamydia. All these are important. Please try to remember how much ever you can, at least four of each of them. And other causes are Entamoeba histolytica, Giardia intestinalis, Trichuriasis, Cryptosporidium, intestinal worms, and Cyclospora. Please try to remember four of these so that you have a good content in your answer papers. What are the host factors that is the child or the adult has to play? Who are the most affected? Those are children 6 months to 2 years. In 6 months to 2 years, 6 months to 11 months is more common because weaning starts at 6 months. And under 6 months, children are also at high risk if they are being fed with cow milk. Apart from this, who are the risk of getting the diarrheal disease, that is elderly because of the decreasing immunity, and immunocompromised individuals, that those are on immunological drugs, people living with HIV, and immunocompromised individuals if they have any immunological deficiency disorders. And the other categories are malnourished individuals, especially with micronutrient deficiency, vitamin A, zinc, have the increased susceptibility of getting diarrheal diseases. Host factors, we have already seen this. And other factors of the hosts are socioeconomic factors, living in overcrowded conditions, poverty, malnutrition, poor hygiene practices such as inadequate hand washing or unsafe food handling, consumption of contaminated water or food. Other factors are environment factors, that is bacterial, more common during warm or summer season. Viral diarrheal diseases are more common during winters. However, rotavirus occurs all over the year. There is no season control over the rotavirus. Poor sanitation and lack of access to clean water increases the risk of contamination. How does it transmitted? That is completely fecal oral route. In between, you might have hundreds of transmitters like flies, floods, floors, fluids, fingers, improper hand washing. All these can lead to development of diarrheal diseases from one to other. How do we prevent and control? The diarrheal disease control program was started in 1980 and it had two components, that is short term and long term. Short term component included appropriate clinical management, and long term component included better MCH practices, preventive strategies, and preventing diarrheal epidemics. We'll see both short term and long term in detail. Appropriate clinical management, it is one of the short one. Under this, we'll discuss about oral rehydration, intravenous rehydration, maintenance therapy, appropriate feeding, what are the treatment is given, and zinc, what is the importance of zinc supplementation. Oral rehydration, oral rehydration therapy is usually done by ORS, that is oral rehydration salts. And we have something called reduced osmolarity ORS, which was launched in 2004 January, and India started using it since June 2004, and India was the first country. And who recommended this reduced osmolarity ORS? That is WHO and UNICEF. Remember, ORS, oral rehydration salts, it is reduced osmolarity ORS recommended by WHO and UNICEF. And when did they start using it? From January 2004. And the second point which you have to write in composition is, that is composition you have to write. One is sodium chloride, glucose anhydrous, potassium chloride, trisodium citrate or dihydrate. If you remember the weight, please do mention. If it is not, it is okay, but please do try to mention the weights of all the 4 components. It will be asked in your viva, and it will be asked in your pharmacology viva also. It would have been asked by now. So please do try to remember the weight. It will give a very good advantage of scoring good marks. Assessment of dehydration. There are two. It is classified into 2 types, that is mild and severe. At one point of time, we had something called mild dehydration, some dehydration, and severe dehydration. Now it has been classified only into 2, that is mild and severe. How do we differentiate? By the patient's appearance. If the patient is thirsty, alert, and restless, that means it's mild. Drowsy, even comatose, or limp, cold, sweaty, skin is feeling too cool, then it is severe. If the pulse is rapid, then it is severe. If it is normal rate and volume, it is mild. Blood pressure is usually normal in mild and unrecordable in severe conditions. Skin elasticity, when you pinch the child, it retracts immediately, whereas in goes back more than 2 seconds, then it is a severe condition. Tongue looks moist, whereas it looks very dry and severe. In children of less than 1 year, anterior fontanelle is normal, and you can see the depression in anterior fontanelle. Normal urine outflow and little or none. So it is not 1, it is none. And what you can estimate out of this is percentage of body weight loss and estimated fluid loss. Percentage of body is 4 to 5%, and it is 10%. How to remember the estimated blood loss? Please add 0 to next numbers and 1 more 0 to here. It becomes 100 ml. This is 40 to 50 ml per kg, and it is 100 ml per kg. Please to remember in a simple way so that it will be easy to write in your exams. How to give the ORS? Actual amount of ORS will be given on patient's desire to drink and by the surveillance signs. Mother should be taught how to administer ORS and how to prepare the ORS. Apart from this, we have intravenous rehydration therapy. That is IV fluids, simply. And what are the fluids used? That is Ringer lactate solution and diarrhea treatment solution. Most commonly what we use is Ringer's lactate. And what is the recommended dose? That is 100 ml per kg body weight is the dose which has been recommended. Remember, any age, it is 100 ml. And when you give this 100 ml, please do remember in your previous slide, that is the fluid loss is 100 ml per kg. The same 100 ml per kg body weight is replaced here. And severe dehydration requires IV fluids, not the mild ones. So 100 ml per kg body weight is given for all the children, whatever the age group is. But how do we give as the criticality here? If the child is less than 12 months, less than 1 year, you divide it into, before this, what we do is we divide this into 2 parts, 30 and 70. Okay. First 30 ml in less than 1 year, we given 1 hour. Less than 1 year, given 1 hour, and 70 ml remaining in 5 hours. Okay, it is total 6 hours, it is total 3 hours. And the older child, you give the first 30 ml in 30 minutes and 70 ml in 2.5 hours. That means under the 1 year age group, you are giving 100 ml per kg body weight over 6 hours totally. In more than 1 year, you are giving 100 ml per kg body weight in 3 hours. The only difference is first 30 ml and the remaining 70 ml. First 30 ml in 1 hour in less than 1 year, first 30 ml in 30 minutes in more than 1 year. Okay. After this, we have to maintain that to avoid the further complications. If the amount of diarrhea is mild after the treatment, you give 100 ml per kg body weight per day till the diarrhea stops. If it is severe, replace the stool volume. If not measurable, give 10 to 50 ml per kg body weight per hour. That's 10 to 50 ml per system. Thanks. Coming from apart from this, since there is an infection, we have to give some antibiotics also. It is considered only if there is a identified cases of cholera, Shigella, or typhoid. In cholera, TMP, SMX, or erythromycin is the drug of choice, and in Shigella, it is ciprofloxacin. I hope you all know what is TMP, SMX, trimethoxazole, and sulfamethoxazole. Okay. And in zinc supplementation during diarrhea reduces the duration of diarrhea episodes and supplements reduces the incidence in 2 to 3 months. That means it is a protective supplementation. What is the recommended? It is given for 2 weeks, under 6 months, under more than 6 months. If it is under 6 months, it is 10 mg, more than 6 months, 20 mg for 2 weeks. Remember, fluids are divided based on under 12 months and more than 12 months, whereas zinc is under 6 months and more than 6 months. Got it? And what are the long-term measures which we are using in this? That is maternal nutrition. If the mother is healthy, child is also healthy. Improved prenatal nutrition reduces the low birth weight problems and improved quality of breast milk, hence no diarrhea because of good immunity and good nutrition. Child nutrition, promoting breastfeeding practices and appropriate weaning practices, not the religious weaning practices, appropriate scientific weaning practices, not like giving donkey's milk, honey, or sugar while birth. All this cause diarrhea and other complications also. Apart from that, scientific supplementary feeding, vitamin A supplementation. The vitamin A supplementation reduces the mortality by 19 to 54%, which is very huge. Other preventive strategies are sanitation, that is construction of sanitation facilities, washrooms, etc. And promoting hand washing. Please do write this point. Without this, it will be incomplete. When all you promote hand washing, before eating food, after eating food, before feeding the child, after defecation, after cleaning the child who has defecated, after disposing of child's stool. These 6 points are very much important for not only for your exams, but for your whole life. And health education, such as how to handle the food, personal hygiene, importance of safe drinking water, how to purify water at household. And immunization. This rotavirus vaccine has been introduced into national immunization schedule. This is a live attenuated vaccine which given in 3 doses at 6, 10, and 14 weeks. 3 doses, 6, 10, and 14 weeks. If someone misses this age, it can be given up to 1 year of age. The first dose can be given up to 1 year of age. Then followed by every 4th week. If you can remember and draw this diagram, nothing like that. Protect, prevent, reduce, and treat. This is the comprehensive picture for vaccinations. Sorry, to treat the diarrheal diseases. With this, we have completed the long answers with another 25 minutes of time. We'll go through all the 3 short answers. Before that, I would like to tell, if there is a long answer, please do finish your long answers in 15 to 20 minutes. Please do not take so much of time to finish off this, because it will have an effect of your short answers also, which will be a good scorers. So please try to finish off the long answers if you are starting from the long answers within first 45 minutes. Maximum grace time you can take is 1 hour, but try to finish it off within 45 minutes of your exam. First one is Chandler's index and its public health importance. What is Chandler's index? It was designed to quantify the number of hookworm eggs present in the per gram of feces. That is 1 gram of feces. Why? To measure the severity of hookworm infection in the population. It is also known by the name known as endemicity index. This is the table which you have to remember. If the number of eggs is below 200 per gram, the hookworm infection is not much of significance in the population. If it is 200 to 250, it is regarded as potential danger. That means it might turn into a health problem, public health problem. If it is 250 to 300, it is already a minor public health problem, needs intervention by public health specialist. If it is more than 300, it is already a major problem. Now it has to be controlled. What are the applications? Assessing the infection intensity by determining the egg count. How severe the infection is an individual or community. And after you start off a monitoring control program, you can use the Chandler index to evaluate the effectiveness. If the worm count the egg count is coming from 250 to 200, that means it is coming down from a minor problem to potential danger. If it is increasing, that means the control program is not effective. And it also helps in epidemiological studies to understand how the distribution of the infection is happening. Apart from this, to target the infections, you can't intervene in all the villages. You can intervene only the high risk areas. You can make a decision whether it is a high risk area or low risk area, and you can allocate the resources accordingly. Coming to the next, that is hepatitis B. What are the types of modes of transmission, prevention, primary and control? We'll write the introduction in every question. Hepatitis B, formerly known as serum hepatitis, caused by hepatitis B virus. If it is getting combined with Delta virus, it is a major problem. It has 2 phases, that is acute phase and a chronic phase. What are the modes of transmission? We have 2 modes of transmission. Sorry, we will go. There are multiple routes of transmission. We will go. Okay. I think some slides are messed over here. Just a minute. There are 2 modes of transmission, that is parental route and perinatal route. Parental route includes sharing needles or syringes, especially among people who inject drugs. That is a behavioral problem. And receiving contaminated blood products or organ donation, which is very rare during nowadays because every blood product is screened. And the other most important are yourself, that is occupational exposures such as needle stick injuries among healthcare workers, which happens during your internships. So please be careful. And the perinatal route, mother to child transmission, one of the most common routes in highly endemic areas like China and Southeast Asian countries. the virus is transmitted from infected mother to her newborn during childbirth. The other routes are sexual route. HBV can be transmitted through sexual contact with an infected person, particularly if there are any open sores or bleeding. And who are at high risk? That is, male homosexuals are at high risk. What are the other routes of transmission? That is from transmission from child to child. What we call it as horizontal transmission, and responsible for majority of HBV infections. The researchers believe that spread occurs through physical contact between children who has skin conditions or scabies or cuts or wounds like that. But till now I have also not seen these cases. This is one of the possibilities. Oh, coming to the typhoid, the disease is characterized by typical continuous fever of 3 to 4 weeks, relative bradycardia, and with involvement of lymphoid tissues. And there are three epidemiological features, that is agent, host, and environment, same as typhoid. For the other infections, agent factors are Salmonella typhi, and reservoir of infections is man is the only reservoir in this infection. There are a case can be characterized into three types, that is mild, moderate, and severe. And the carrier is a convalescent or a chronic carriers. Chronic carriers are those who excrete the bacilli for more than a year after clinical attack. A chronic carrier may excrete the bacilli for several years, either continuously or intermittently. Salmonella typhi, once lodged in the human body, it can persist for almost 20 to 50 years. And fecal carriers are commoner than urinary carriers. The famous case which you have to mention during your exam is Typhoid Mary, who gave rise to almost 1300 cases, and she was a chronic carrier. She used to work in one of the restaurants. Source of infection. Sole source of infection in the feces is the feces or urine of cases and carriers. The bacilli are excreted for varying periods in feces and urine. And the host factors include, it can occur in any age. Highest incidence occurs usually in 15 to 19 years of age group, 5 to 9 years of age, 19 years of age group. And it gives an lasting immunity, but there is no evidence that second attacks cannot happen. And more cases are reported in males, basically because of increased exposure to infection. And carrier rates are more common in females. What are the other environment and social factors? It is observed all throughout the year. Peak incidence is reported during July and September, and it coincides during the rainy season and increase in fly population. And outside the human body, the bacilli are found in water, ice, food, milk, and soil for a various periods of time. It can survive. But typhoid bacilli do not multiply in water, but they can survive. How long they can survive? Over ice and ice cream, they can survive for a month, and for 70 days, it can survive for in sewage water and irrigated soil, they can survive for 70 days. Why does it have an importance? Many of the urban and metropolitan cities, they are using the recycled water for growing vegetables. Hence, the irrigated soil which they are using, or the sewage water, filtered sewage water which they are using for growing vegetables, are a potential risk of enteric fever. And one important thing is the typhoid bacteria can grow in your milk without changing its taste or color or appearance. Incubation period is 10 to 14 days. And when it is disease born, it can be more longer than 14 days also. Modes of transmission spread chiefly through medium of contaminated water, food, milk, and vegetables. And flies play a very important role in sporadic incidents. Sporadic means it is happening here and there, it is not happening at one place. And direct transmission do occur, but in a very small proportion. How? the people who are usually handling the excreta of the cases, that is in the hospitals, the housekeeping staff who are handling all these cases, they might transmit the typhoid disease. The most important factors are cultural factors and economic factors. If you are able to remember the diagram, please do write this. That is feces and urine from cases or carriers transmitted through water, soil, flies, and fingers. Okay. If the individual is consuming foods or raw food or improperly cooked food, undercooked food, then the risk of typhoid fever is higher. Clinical features. Usually the onset is very insidious. It is not sudden in onset. Chills and fever. During the prodromal stage, there may be malaise, headache, cough, sore throat with abdominal pain and constipation. And the fever ascends in a step ladder fashion. This is the diagnostic sign in typhoid, that is step ladder fashion, and it reaches the plateau after 7 days. That means the temperature raises by 1 degree, stays for a day or two, then it raises by 1 degree, it stays. Third day it will raises for a degree and stays. Fourth day it raises, fifth day raises, sixth day raises and stays. After 70 days, it raises and stays constant. 7 to 10 days, it stays constant. This is the step ladder fashion, which is typical and characteristic for typhoid. The patient looks toxic, and he might have marked constipation or pea soup diarrhea. Looks like pea soup. Hope you people don't have tonight. And later, the complications might be splenomegaly, abdominal distension, and tenderness. Relative bradycardia. What does relative bradycardia mean? It simply means when there is raise in temperature of your body, there is a raise in your heart rate also. However, in typhoid, if there is a temperature is increased, the heart rate decreases. It is inversely proportional. That is what it is called as relative bradycardia. Dichrotic pulse can feel double pulse, and occasionally meningismus might occur. Rash does not occur till the second weeks, and it is very rare. The serious complication occurs only in 10% of the typhoid fever patients who are being ill for more than infected for 2 weeks. Otherwise, it subsides by then. How do we prevent and control? There are 3 lines of defense against typhoid fever: controller of reservoirs, control of sanitation, and immunization. How do we control the reservoir? We know only human being is the reservoir. By early diagnosis, which is very important. How do we do the early diagnosis? By culture of blood and stools. Notifying the disease. It is one of the notifiable diseases. You might have a short question called short answer called list the notifiable diseases in India, which will come later. And isolation of the cases. Since typhoid fever is infectious and has a long course, cases should be admitted because the feces which they are excreting into the environment causes spread of the disease. Okay. And cases be isolated till 3 bacteriologically negative stools and urine reports are reported. This is the duration of the hospitalization, and this is the reasons for hospitalization. Treatment, fluoroquinolones is used, and most important is this. How do we disinfect stools and urine and clothes? Stools and urine are the sole sources. There is no other source of infection to spread. It is disinfected by adding 5% Cresol solution for 2 hours. Hold it for 2 hours, add with 5% Cresol solution, hold it for 2 hours, then discard it. Clothes in 2% chlorine solution and steam sterilized. One of the reasons why white clothes or bedsheets are used in hospitals because chlorine solution causes discoloration. Follow-up stools. Follow-up of stool and urine examination should be done every 3rd month, that is 3 times a year, and 12 months after discharge to see their negative. Why? to decide whether they are carriers or not. Control of reservoir, that is the carriers. Identification by cultural and serological examination, that is detecting BI antibodies in the serum. Treatment, intensive course of ampicillin or amoxicillin with propanacid for 6 weeks. Add probiotics with amoxicillin to avoid acute gastroenteritis. Surgery, if required, that is cholecystectomy with ampicillin therapy. It is very rarely done. Surveillance should be done so that the people who are carriers are prevented from food handling, milk or water for others. The other important one is washing hands and hygiene. Control of sanitation by providing safe water supply, boiling or treating water at the household level, and chlorination. Water sanitation, it does not only ensures that the typhoid does not spread, it also prevents the spread of typhi in communities. So hence, water and sanitation infrastructure is very important in the community. Safe food practices, avoiding street food and ensuring that food is prepared hygienically and not eating on the roadside is more important. Travelers should avoid food from unverified sources and drink bottled or boiled water all the time to avoid typhoid infection. Coming to the immunization, vaccination is one of the primary methods preventing typhoid fever in travelers to endemic areas and in outbreak situations. There are two types of vaccines, that is polysaccharide vaccine, which is divided into subunit vaccine, and a live attenuated vaccine. Polysaccharide vaccine is composed of capsule, VI capsule polysaccharide, 1 dose IM after 2 years of age and revaccinate after 3 years. Not once after 3 years, every year, every third year you have to vaccinate them. The other one is TI21 alpha vaccine. It is a live attenuated vaccine. TY2 strain given orally, approved for giving more than 5 years of age, schedule 3, that is 1, 3rd and 5th day, 3 doses. Whereas capsule vaccine is 1 dose. It is 3 dose vaccine repeated every 3 years, that is 1, 1st, 3rd and 5th day. I have completed 5 minutes early. I would like to tell you, if you have any questions, please do ask or drop with the learning council manager for the questions. And please do use the subscription code for good discounts from the Auricle. Thank you so much.